morning, everybody. I would like to talk to you about the FSHD evidence-based guidelines that just came out and explain to you how we got to the guidelines and go over the guidelines themselves. It's really, this is the first comprehensive approach to trying to kind of make care for FSH muscular dystrophy unified across medical centers and among physicians. So next. But just a little bit of background. So as you all know, FSHD is a relatively rare disorder. And because of that, it's difficult to come up with evidence-based guidelines. Evidence-based means that you go to the literature, and there are a lot of papers that you can go to use for evidence for certain approaches to taking care of patients with FSH muscular dystrophy. So the consequence of FSH being a relatively rare disorder, there are few physicians other than neuromuscular specialists who have experience in caring for individuals with FSH, and even general neurologists and even less primary care physicians have little or no knowledge of this disorder and how to take care of patients with FSH. There are actually two publications that have outlined consensus-based guidelines, and by that we need expert opinion. So a bunch of us neurologists get together and say, okay, what do we do for, problems breathing in FSH? What do we do, for taking care of pain in FSH? And we just sit around and share our experiences and put them together as expert opinion. The problem is these guidelines are usually not widely distributed and not widely known outside of the neuromuscular community. Next. So the CDC several years ago has taken upon itself to really create guidelines for a number of rare disorders, including a lot of neurological disorders. And the American Academy of Neurology set out to develop evidence-based guidelines for FSH muscular dystrophy. And this whole process started back in, I think, 2011. And the purpose is to make these guidelines as widely available as possible within the medical community. The panel that reviewed the evidence and set the guidelines was composed of neuromuscular specialists like myself, a rehabilitation physician, and a physical therapist. Additionally, there was input from a wide group of individuals representing different specialties as well as patient advocates, including the FSH Society and the NBA. Next slide. So let me talk quickly about the process of how we got to the guidelines. So first, we gathered the evidence. So the way we did that is basically review all the literature that has been written by FSH, decide what are the most important clinical questions that we need to address. And of course, we have to limit ourselves to where there's evidence. Analyze the evidence and then provide practice recommendations based on this evidence. Next. So this is kind of the flow of the process. We developed a set of questions that we need to answer. We looked at the evidence. We reached the conclusions based on the evidence and through what's called a modified Delphi consensus. We reached recommendations for each of the questions that we set out to answer. Next slide. Next slide, Jim.
Sorry, I'm trying to advance them, and they seem to be stuck. Hold on. I'm sorry. Is it the next one after this?
Yeah.
There we go. Is that it? Sorry about that.
So So basically what was done is a literature search, and we came up with 977 abstracts of journal articles. And there were very strict criteria as to what we consider good evidence. And you see some of those on the slide, what we've included, what we excluded. And the 977 abstracts were whittled down to 176 articles that we thought contained good evidence that we can look at. Next. So the topics that were covered by the AAN guidelines are the following. One is we wanted to look at genetic testing for FSHD, for FSHD type 1. And we only looked at type 1 because type 2 is recently described and there's not a lot of literature on it just yet. And the question is, how good is the test? How sensitive is it? And how specific is it? And then we looked at factors that are associated with loss of what we call clinically meaningful milestones. So what are the factors that somebody with FSH has that may predispose them to certain complications? We reviewed all of the drug trials in FSH, and then we looked at the complications of FSH, including hearing loss, retinal vascular disease, heart involvement, and lung involvement. Then we looked at pain, exercise, and scapular fixation. These are all of the topics where we found enough evidence that we can talk about them and make recommendations. Obviously, it's not a complete list, but it's not meant to be at this point. This is really the base guidelines that over the years we can start to build upon. Next slide. And so these are the recommendations, and I'll show you at the end that these recommendations are accessible to everyone. You can download these, and you can. There's a section for patients, a section for physicians, and so they're really meant to be as widely distributed as possible, and for patients who go to physicians who don't know very much about FSH, you can take those guidelines to them and present guidelines for them to follow in your care. So let me go over what we talked about and what the recommendations are very quickly. First, we talked about is genetic testing, and it turns out that the commercial testing that's available nationally and internationally is actually very good, very sensitive, and very specific. There are very few instances where there's either false positive or false negative test. And then we looked at factors that can predict severity, and the one thing that is the most consistent predictor of severity is how large the deletion is. The deletion meaning, as many of you know, FSH is the result of a loss of a certain number of repeats, whereas somebody who doesn't have FSH has more than 10 repeats, and somebody with FSH has between 1 and 10. And so we now know that the most severe form of FSH are in the folks who have 1 to 3 repeats. And there's a wide variation in the rest of the population as far as how severe they are, but predictably, the ones who have the 1 to 3 repeats are usually the most severely affected. And that's really important because that group of patients are the ones that need closer monitoring, because they're the ones who are predisposed, as you would see, for some of the complications. And so next week, we looked at monitoring for complications like breathing. And it turns out about 7 to 10% of patients with FSH will get some type of breathing problem, usually not significant, only about 1 to 2% will need some type of help with their breathing. And so the recommendation is that everybody get a baseline breathing test. And if it looks good, then they don't have to repeat it unless they have certain things on their exam. If they are severely weak, especially if they're and if they have scoliosis, if they're wheelchair dependent, or if they have any other related conditions that affect the breathing, like somebody who's a chronic smoker, for example. These patients will need yearly monitoring. And then the other recommendation to the physicians taking care of patients with FSH is always ask about sleeping habits, because the first sign of problems breathing is usually at night when you're lying down. And so the physician should ask about signs of interrupted sleep, and that's usually somebody who wakes up in the morning headache, so somebody wakes up feeling not refreshed from their sleep, somebody who's sleeping, seems to be very sleepy during the day, and so that if there are symptoms like that, then they should be referred for a sleep study. The other important factor is that sometimes, because this comes on very slowly, patients with FSH don't have symptoms of breathing problems until they're put in a situation like general surgery, the general anesthesia, where the breathing problem becomes very evident because of the medication that they're taking. So it's very important for somebody with FSH before undergoing major surgery to get a breathing test done. And as far as cardiac abnormalities, the evidence is that really there's not much cardiac involvement in FSH, and there's no need for screening for either by EKG or by a cardiac ultrasound or echocardiogram. So there's no need to monitor the heart. Next. So again, there are two conditions, the retinal vascular disease and the hearing loss. Now, in retrospect, we know that they only happen in any significant manner to the patients who have 1 to 3 repeats. And predominantly, these are the kids who have very early onset disease. And these are the ones that really should be very carefully monitored, because if retinal vascular disease is not treated appropriately, it can lead to vision loss. Hearing loss is also something that needs to be monitored very carefully in very young kids with FSH, because you don't want to miss hearing loss and not treated with a hearing aid, especially in the developing stages of a young child. They may have a delayed speech and language development. So this is something important for the kids with FSH, and also those who have very large deletions or just 1 to 3 repeats. Pain is something in when we survey patients with FSH, it's a common problem. About 80% of patients with FSH complain of some type of musculoskeletal pain. Only about 10% really report pain that's significant, that needs ongoing treatment. And the reason this recommendation is put on there is because a lot of you guys don't complain to us. And so this is something that physicians should ask about and address appropriately with patients. Usually, depending on the level of pain, and physical therapist is often very helpful in trying to kind of figure out what the source of the pain is. And then sometimes just with stretching and some exercises, the pain can be taken care of, but sometimes you need to move on to medication. Treatment, we looked at all of the pharmacologic, the treatment trials that have been done in FSH so far. None of the drugs that have been described, that have been tried, the albuterol, the corticosteroids, or the distiazin, have worked. And this is based on clinical trials, so there's no reason to prescribe them in FSH for the purpose of improving strength because they just don't work. Scapular fixation, again, we reviewed the literature, even though the literature was weak, but there's pretty good evidence based on the literature that patients who get surgery, appropriate type of surgery, will gain range of motion in the movement of their arms and shoulders. It is important that surgery be done by surgeons who have done it, who have experience doing the surgery, and done on the appropriate patient. And you can assess that at the bedside. Your physician can manually fix your scapula and find out how much range of motion you can gain by surgery. Next. And the last couple of things. One is the exercise. There's a lot of evidence now, even more recent evidence that based on studies that were published after we came up with the guidelines that aerobic exercise is good for patients with FSH. It's not harmful. In general, aerobic exercise is not detrimental at all, and most patients who do that on a regular basis feel better. It's important to talk to a physical therapist about which type of aerobic exercise is most appropriate for you individually based on your limitations. As far as resistance or weight exercises, you really have to limit yourself to small weights and work very carefully with a physical therapist to see what are the safe exercises that you can do. These are kind of very broadly the outlines of the recommendations that we have. Can you move to the next slide? And I just have on here a link to the guidelines, and you can see the website, the web link to aen.com/guidelines. And this is just a snapshot from what's on there. There's a description of, and so this is for patients and families. It describes what FSH is all about, how the guidelines were arrived at, and they have the whole set of guidelines in there. And they can be downloaded, printed, and you can take them to your primary care provider or your neurologist. And this is, again, the whole idea is to disseminate these guidelines to as many physicians as possible. And I think part of that is not only us distributing those guidelines, but also you taking those guidelines to your physician. And I'm going to stop here and take questions at this point.
Thank you so much, Dr. Tawil. I have some questions that were sent to us by people who couldn't participate today, so maybe I'll start off with that. Here's a question. Says, I would like to get your thoughts on physical activity for young adults who have been diagnosed. Are they better off staying highly physically active, more specifically doing weight training, or should they try to conserve their muscle strength?
Again, I mean, as we talked about, there's increasing evidence that aerobic exercise is good and makes people who have FSH feel better and are more active and more physically fit because of it. Now, there's a certain break point. If somebody is very weak, they may have limited capacity to do certain types of exercises. So it's kind of a combination of remaining as active as possible without draining yourself so that you cannot go through the whole day. And this is why it's really important to not go out on your own, but actually seek the help of a physical therapist and work closely with them to see what is the most appropriate type of exercise for you to do. And again, the emphasis is more on aerobic exercise. Weight training should not be weight training to try to kind of build muscle, but more with light weights because if you use high resistance or heavy weights, depending on how affected you are, you may get some overuse injury to your shoulder, for example, just because you're overdoing it. Everybody has to remember that their joints are as good as the muscles around them. So if your muscles, for example, around your shoulders or your knees are not very good, you have to be very careful about weight training.
Okay, thank you. We have a Stephen Bertanoff. I'm not sure. Anyway, I see your hand is raised. Would you like to ask a question? And remember to unmute yourself. Hello, Stephen. Would you like to ask a question? Okay, let's move on to Carden. Carden, would you like to ask a question?
Hello. Yes. Can you hear me?
Yes. Go ahead.
Okay. Hey, I had a couple questions that weren't posted in chat. Did you happen to see them?
Why don't you go ahead and read them out to everybody?
Okay. Is there an answer to why DUX4 lacks the poly A tail? This was more specifically in the research that you wrote.
I'm sorry, I'm not. I didn't understand the whole question. Can you repeat it? Your voice is not very clear on my phone.
Why does DUX4 lack the poly A tail?
Oh, okay. I mean, this is more of a scientific question. It's complicated. It's because it's what we call a pseudogene, and so on its own, it does not produce a DUX4 protein unless there's a poly A tail next to it that it can attach and can produce a stable RNA. Does that explain it?
Thank you.
Okay.
Okay. Carden,
yes,
I see you had another question that has to do with genetic testing. That was interesting. You wanted to know why FSHD2 genetic testing is not readily available and what makes it so difficult to diagnose.
It's just there are several levels of testing that you have to do, and it was really developed all in one lab, and most of the data was generated from one lab in Holland, and it's just very, very tedious process. But I'm happy to say that recently the University of Iowa lab is now offering FSHD2 testing.
That's great to know. Okay, I have Michael Forsett has his hand raised. Would you like to ask a question, Michael?
Yeah. Hi, Dr. Tawil. I actually saw you several years ago, and I was involved in the albuterol study. I don't know if you remember me or not, but one of the issues that I've run into here in Raleigh, North Carolina, is that I haven't had a whole lot of luck finding a neurologist, something that you mentioned early on in your presentation, that knows a lot about FSH, and I was actually wondering about the idea of coming to see you and wanted to see how I can go about in making that happen.
Yeah, you're welcome to come and see me again. I mean, I can give you our contact number. It's 585-275-2559.
2559?
Yeah.
Okay. Thank you so much.
Welcome.
Great. Thank you. Here's another question that came in earlier through email. A patient says she has noticeable hearing loss. You've already answered the question. It is related to FSHD. She's wondering why would FSHD affect hearing? Is it known what?
No, I mean that's one of the. Similar to the retinal vascular disease, we don't know the connection between the two. I mean, it must be that DUX4 somehow affects processes within the retina, the retinal vasculature, as well as the cochlea in the ear. And we don't know exactly how that happens. It's difficult to do a biopsy of your retina or your cochlea in the ear. So we don't know exactly what that process looks like, under the microscope. So we don't understand that connection. But it's clearly connected, and as I said before, it's the patients who have the fewest remaining repeats, 1 to 3 repeats. That usually translates, when you do genetic testing, they don't give you the number of repeats, they give you the size of the remaining piece of DNA. So anything between 10 and 16 to 18 implies that you have 1 to 3 repeats. So these are the people who are most at risk for the complications.
Thanks very much. I see Kevin with his hand raised. Kevin, would you like to ask a question?
Yes, please. Doctor, I was wondering if you are aware of any advances in the treatment for FSH, or upcoming or in the pipeline. Thank you.
Yes, I mean, since the scientists have figured out that DUX4 is the primary culprit in FSH, the expression of DUX4 in muscle is what causes FSH. There's been a lot of work being done on treatments, and I can tell you 5 years ago, no drug company was interested in FSH. Now there are many drug companies working on treatments for FSH. In fact, there is now ultimately what the best treatment is going to be something that targets the source, meaning that if there's a way of turning off DUX4, that would lead to stopping FSH basically and potentially reversing it. But there are other approaches that you can take also to treating some of the what we call the downstream effects of DUX4 expression in muscle. And so there's a company called aTyr that's now looking at a very new product that they're developing that's anti-inflammatory. And they think that, and we know that at any one time, patients with FSH have inflammation in one or more muscles. And this company is doing a study right now. There are several sites in Europe. There are 2 sites in the U.S., including our medical center and Ohio State University in Columbus. And so they're looking for very specific patients to do this on. And so what they will do is scan somebody with an MRI, and based on the appearance of the MRI, if there's an indication that any one muscle is inflamed, then that person will qualify for the study. Now this is an early phase study. They're looking to give this treatment. It's given intravenously once a week, and they will repeat the MRI, and if the evidence of inflammation goes away, then it means that their medication is doing what it's supposed to do. And the next step will be, after this early phase study, if they're successful early on, they'll do a second study that goes on for a longer period of time, and then they will determine if turning off the inflammation actually helps prevent the muscle from getting worse. That make sense?
Thanks. Dan Perez, has his hand raised. Dan, would you like to ask a question?
Sure. Can you hear me?
Yes.
Yeah, great. Dr. Tawil, I just wanted to thank you. Just a comment. I wanted to thank you for this extraordinary effort and for the excellent work. And a lot of effort went into this, and we're most appreciative as a community. And I guess the question that I have is, what kind of response have you seen now that this is out, and is there anything that has been surprising to you?
Response, you mean from the medical community?
From the medical community.
I don't know. I mean, I'm not aware of, and maybe I'm not in the middle of it. I mean, I think it's something that I am also interested in finding out how the response has been. I know that in the past, the AAN, whenever they publish guidelines, evidence-based guidelines, these are the most downloaded articles that they publish. And so it would be interesting, and I haven't gone back to the AAN and asked them that, but it would be interesting to see how this is going, because they can keep track of how many people are downloading the guidelines.
Good. And thank you again.
Thank you.
Okay.
There's a question from Sue. Sue, would you like to ask a question?
Sure, yes. I was wondering, you mentioned the anti-inflammatory process that you're looking at now under your current study. Is there any information about the effect of some of the other biologics, such as Humira, when taken for other conditions on FSH?
No, there is no, and this is a very good question. I mean, I think one of the issues has been really that we don't know whether the inflammation is a primary thing or kind of a byproduct of the muscle fiber destruction. And so, but many years ago we did a trial with prednisone, which is not a very specific anti-inflammatory, but it's a very powerful one nonetheless. And we did it in 15 patients. We gave them high doses for 3 months, and there was it did not make a difference in their strength. And actually, the only thing that happened is it became a lot of weight. But it is a good question. I mean, could it be that a more targeted new biologic, would it be useful for FSH? I don't know. I mean, I think this is a reasonable question. But again, I'm on the fence as to being certain that treating the inflammation is really going to make a difference, as opposed to it being just a byproduct of the underlying dystrophy. And so, you don't want to go in with a big hammer that can cause a lot of side effects when you're not certain about what's going to happen. I think that to me, what was interesting in the aTyr approach is that their product is actually seems to be very safe and very well tolerated, and so it kind of and yet in the lab experiments that they've done, it seems to be a fairly powerful anti-inflammatory. So it again, it's kind of risk-benefit, and I thought, there was not a lot of risk to it, so it's worthwhile trying.
Thank you. Here's another question that came in by email. The patient says, I need more sleep than the average person. I seem to fatigue faster than my cohorts. Is this common with FSHD?
I think this is common. This is common in really all of the muscular dystrophies, and it has to do oftentimes with the increased energy that somebody with FSH has to put out to achieve the same amount of walk or climbing stairs that anybody who doesn't have a dystrophy has to expend to do the same amount of work. But the other thing that again, I don't know how severe the person asked the question is, the other important thing is to make sure that there's not other issues that are causing fatigue. I mean, fatigue can be caused by many things. And one of the common things is the problem of sleep. And so, again, this is what I mentioned. This is one of the things that physicians should be asking their patients. And if somebody's predisposed, if they have lung capacity that's reduced, they may not have any problems when they're sitting up, but when they lie down, their lung capacity is smaller because they don't have gravity helping expand their lungs, and they may have nighttime what we call hypoventilation, meaning that they are not getting rid of their carbon dioxide and they wake up fatigued in the morning. So this is something that needs to be looked into as a potential cause for daytime fatigue.
All right, thank you. There's a question from Mimi Brown. Mimi, would you like to ask a question?
Sure. I would like to know if they're doing any more clinical trial studies on the myostatin drug.
You probably know that the Meyer 29 was a trial back in the mid-2000s. There are many companies working on other medications in the same pathway, meaning kind of in the myostatin pathway. So yes, there are many companies working on different formulations of medications in that pathway, and some of them are considering trials in FSH. None of them active right now.
Yes, that's good to hear, because my son was in the clinical trial study a few years ago at Johns Hopkins, and a lot of they had some good results, and then so I just was wondering. That's good to hear. Thank you, doctor.
You're welcome.
Thank you. Jacqueline Farrell has her hand raised. Jacqueline, would you like to ask a question?
Yes. Can you hear me?
Yes.
Yes. I live in Richmond, Virginia, and I know they had genetic testing at Johns Hopkins. I didn't know if there was any place closer than that to me to be able to have that done. I was diagnosed about 15 years ago, but I've never had genetic testing done.
Well, genetic testing is actually
So, Jacqueline, I think we're getting feedback.
Okay. Sure.
All right, go ahead.
Okay. So genetic testing is actually done in a couple of labs nationally. And so, to my knowledge, it's not done at Johns Hopkins. So it can be done anywhere. You don't have to be in any particular, city or medical center to get this done. It's done in, again, two main labs, one in the University of Iowa and one in Athena Diagnostics, which is in Massachusetts.
Very good.
Okay.
Thank you.
Thank you.
Let's see. Carden, is your hand still raised? Do you have another question?
Yes. Are there people with 1 to 10 repeats with a fragment size is greater than 38 kilobytes and show no symptoms?
I got parts of what you were saying. I could not hear you very well. So are there patients, let me repeat the question as I heard it. Are there patients who have FSH who have more than 38 kilobases? Is that what your question is?
I believe the question is that people who have no symptoms, who have between 1 and 10 repeats, but are non-manifesting or have no symptoms.
Yes, and That's a very good question there. And again, just as the people who have 1 to 3 repeats seem to be on the more severe end, those who have between 8 to 10 repeats are, in general, the most mildly affected, and also are the ones who tend to present later at a later age, or not present at all. I mean, not even have symptoms.
Great. Okay. I was curious.
And then I'm guessing we don't know the reason why they're asymptomatic.
I think we're starting to understand a little bit because of the interaction between FSHD1 and 2. That there are probably certain, and so we know, for example, that FSHD2 is caused by a mutation in a gene called SMCHD1, and there are families who have both FSHD1 and 2 in the same family, and if somebody has, for example, 7 repeats, and has FSHD1 and have an SMCHD1 mutation, they're usually much more severely affected. And so this is something that we know very clearly about this particular gene, but there are probably other genes that can modify how somebody presents, either protect them or make somebody more predisposed, like somebody who has 9 to 10 repeats, make them more predisposed to showing signs and symptoms. So these are what we call modifiers. These are gene modifiers that can explain some of the sometimes wide differences we see within the same family of people who have the same number of repeats, but somebody is very severely affected and somebody else is minimally affected. So we're just trying to...
Okay, thank you.
Okay. Let's see. There's a question from Polly. Polly, would you like to ask a question?
Yes, thank you. I was wondering if Dr. Tawil could give us some options that are available for FSHD1 females who may be interested in starting a family.
Yeah, I mean, so there is one of the difficulties with FSH is that the genetic test for FSH needs a lot of DNA because it's and so this precludes doing what we call preimplantation diagnosis. Except in certain situations, which means that pre-implantation diagnosis, maybe I should explain what that is, or do you know what I mean by that?
Well, it'd probably be a good idea to explain it.
Yes.
Okay.
Go ahead and explain that.
So pre-implantation diagnosis is when you can take an egg from a female and a sperm and fertilize them outside of the womb and grow them to basically divide into several cells, and then you can take one cell and test it. Then you'd be able to determine if that very early embryo is going to develop FSH or not. If they're not, then you can implant it in the mother, and you can be certain that they don't have FSH. The problem is you cannot do genetic testing on DNA from just one cell, but you can do it in a different way. And so you can do pre-implantation diagnosis based on what we call linkage, and it's a little bit complicated to explain, but for that to happen, you really need multiple members of the family who are affected to, and preferably more than one generation, to donate blood to get tested. And then by looking at the pattern of the DNA in everybody, they can figure out, again, with pre-implantation diagnosis, based on DNA from one cell, what the probability of that embryo is to develop FSH. So in FSH, to do pre-implantation diagnosis, the bottom line is that it really only works if you have multiple affected members of the family in more than one generation that can be tested in order to do that.
Oh, that's complicated.
Yeah.
Something that a lot of women ask us about also is the impact of pregnancy itself on a mother who has FSHD. Can you speak to?
Yeah, that's a very good question. And there are actually two papers on that, one that came out from our medical center and one from Germany. And both of them, and I think most women who have pregnancies who have FSH know that it takes a toll on them. And most women report that they're worse off after the pregnancy, that there's a loss of some of their strength. That seems to be fairly consistent in the studies that were done.
Mm-hmm. All right, thank you. Len has his hand raised. Would you like to ask a question?
Yes, I would. I understand that the guidelines are based on FSHD1. Would it make sense for an FSHD patient type 2, like myself, to share the guidelines with my care team? I mean, it's coming one again in town.
Yeah. Again, the problem is, as I mentioned before, FSHD2 is really kind of a new type of FSH. It's only been for the last 6 or 7 years. In general, I mean, I think we know that both FSHD1 and 2 eventually have the same mechanism. They're caused by the same thing, even though they're genetically different, but both of them are caused by the expression of DUX4 in muscle cells. What we know is that in general, FSHD2 looks very much like FSHD1. What I have not seen myself or have seen published anywhere are some of the more severe forms of FSH, like the infantile onset FSH, the type 1. I don't think has been reported in FSHD type 2. Similarly, the complication of hearing loss and retinal vascular disease has not yet been reported in FSHD2. So I think the guidelines, by and large, as far as recommendations, apply for both. What some of the predictors, for example, the size of the repeat, obviously does not apply to FSHD2. There are maybe certain things that are that we can measure, that we're going to be able to measure, and these are things that we're looking at now that can tell us if somebody is more predisposed to getting more severe disease with FSHD2 or not. And that has to do with the methylation level of the DNA on chromosome 4. The methylation level basically reflects how tightly bound the DNA is around the D4Z4 repeat. The less tightly bound they are, the more likely you're going to get DUX4 expression. The more tightly bound it is, the more it's suppressed. And so we're looking at kind of identifying, the best marker for methylation in FSHD type 2 and see if that may be helpful in trying to prognosticate for patients who have FSHD type 2. But again, in general, as far as exercise and everything else, I think it applies for both.
Thank you so much. We only have a few minutes left. I think we have time for maybe one or two more questions. Stephen, you have your hand. You've had your hand raised. Do you have a question?
Can you hear me?
Yes.
Hello. Okay, great. My speaker wasn't working. Sorry about that. I posted a couple things on the comment chat on the side, and kind of touched on one with ATAIR and the cyclocline therapy that they're starting. I don't know if you can elaborate more on what you're seeing with that. If not, that's fine. I guess my other questions were, any thoughts on adebenone? I know that they recently found treatment with Duchenne's with adebenone, meaning that there's possibility with inflammation in that. And then also autologous muscle cell and or fat cell injections. Any thoughts on that?
A little hard to make that out.
Yeah.
Did you hear that, Rabi?
I heard some of it. I know that the question was about ATAIR and inflammation, but I didn't get most of it.
Can you hear me better now?
Yes, that's better.
Okay. Just curious about more thoughts on the cyclocline therapy, what they're seeing right now, if anything. But then also, if you have any thoughts on adebenone, and I know that they just recently found some help.
Oh, it's very hard to hear you. You're chopping up. Sorry about that.
Yeah, I can't understand. There's a lot of echo, it seems like.
Can you try talking quieter?
Stephen, do you want to try one more time? Just maybe a little more quietly and slowly?
Yeah, can you hear me better now?
No. No, there's something. Your phone
if I type it in, I did type it in on the side presenter. I don't know if anyone got any of the question that I had.
I think we'll have to give up on this one because it's just not.
Can you hear?
Hello?
Hello? We typed in on the side. Can you see the chops on the side?
Oh, yes. Okay. Oh, yes. There's a lot of. Okay, let me see if I can find a huge number of questions here. Let's see. Oh, you were asking about idebenone? Is that a?
Yeah.
And then there was another question about autologous treatment with, it says muscle and mesenchymal cells. Maybe you're thinking about maybe stem cell derived, like cell transplant type therapies? Why don't we?
Yes, exactly.
Okay. All right, Rabi, any thoughts about stem cell or cell transplantation therapies?
I think this is not something that the type of treatment has been tried in Duchenne in the past with not a lot of success, and I'm not sure it's very applicable to FSH at this point. I know that if people go on to the NIH website, clinicaltrials.gov, there is actually a stem cell trial in FSH being conducted in Iran. I don't know on what scientific basis, though. So I don't think there's a role for stem cell therapy at this point in FSH.
Okay.
Any thoughts on adebenone?
Adebenone.
For idebenone and FSH?
Yes.
Not to my knowledge, no.
Okay. There are quite a few more questions, but it is 9 o'clock. Would you have a few more minutes to answer a few more questions?
Sure, yeah.
Okay, thank you. All right, so let's see. There's a question about cardiac arrhythmias and atrial flutter. Are these typically related to FSHD? And I guess clinically, what's their significance?
So, I mean, the only evidence of cardiac involvement, and again, it's very, very hard to tease out whether the reports of patients who have these and who have FSH have it because of other cardiovascular risk factors, as opposed to it being connected with FSH. But if there's anything that happens with FSH, it's some of those atrial arrhythmias, and they're usually very benign. Now, atrial fibrillation is not necessarily benign because it can predispose to clots. And so somebody who has chronic atrial fibrillation may need to be on an anticoagulation. But again, I don't think that there's enough evidence from what we've looked at to suggest that people need to be screened for these, because most people will have symptoms if they have atrial fibrillation or atrial flutter. Again, they are potentially dangerous arrhythmias in the long run, but they're not as severe as some of the what we call ventricular arrhythmias. And again, I don't know if this person was asking that himself, and if there's any other risk factor for heart disease that may be an explanation for the arrhythmias that they have.
Right. Okay, thank you. This is a kind of intriguing. Somebody says that they is there a mechanism to have the recommendations sent to specific physicians? That he found that physicians would not accept these guidelines sent to them by email. He had to work with the MDA office. The doctor cited legal issues. Do you know, Rabi, what that might be about?
So this is somebody who sends those guidelines to their physician, and they were not ready to abide by them?
Right, and they cited legal issues. They wouldn't accept it when the patient emailed the guidelines to them.
That's news to me. I don't know. I mean, these are published guidelines. I don't know of any legal implication that would prevent the physician from looking at those guidelines. I mean, we do that all the time as physicians.
Yeah. They're also available to download directly from the American Academy of Neurology site, so perhaps doctors would be more comfortable downloading them from a known entity, I suppose.
Right. And so, and there are downloads specifically for physicians, and so that are slightly different than the guidelines that are made for patients and families. So there are, when you go to that website, there are specific. There's a summary guideline with a lot of explanation, as well as a set of slides that they can look at to go through the whole process.
Okay. So we have a question on the somewhat related, I guess, massage, and another on acupuncture for, I suppose, for relief of some of the pain or stress to muscles.
Yeah, I mean, I think both of them are reasonable approaches. I mean, especially if they result in relief of pain, and not necessarily, and without the use of medication, that would be good. I mean, acupuncture is one good therapy for pain, I mean, it doesn't do a lot of other things, but it does work for pain. And often massage will work as well because in somebody with FSH tissue, there's a lot of asymmetry in the way they're affected. There's a lot of stress on a set of muscle on one side, and massage may help with that.
Okay, thank you. And then here's a question. I'm going to slightly reinterpret. It says, do you anticipate any blood test that precludes the need for muscle biopsy? I think maybe the underlying question really is, why is a muscle biopsy still being done often as part of the diagnostic workup when there is a genetic test that would definitively tell you if you have FSHD?
So the sequence of events, and again, there's a flow chart in the actual journal article of the guidelines that shows that there's no need for a biopsy. The only time you would do a biopsy is if somebody looks like they have FSH and you do all of the genetic testing and it comes back negative. Then you have to do a biopsy to try to kind of guide where to go next as far as figuring out what they have. So no, the first approach is you don't need a muscle biopsy to make a diagnosis of FSH.
Okay, thank you very much. And I think, good, let's see, just let me check to see if there's anything else pressing. There's a question if high red blood cell counts might be related to respiratory, issues.
They might, yes.
And if so, would they be reduced by using a BiPAP machine at night?
Yes. I mean, but usually it's not so much because of, that would be a little bit unusual though for FSH because it's usually people who are not able to get enough oxygen in where the red blood cell count goes up, not people who are not able to get rid of their carbon dioxide. But if it's severe enough, then they will have problems with getting oxygen as well. But I've never seen somebody's red blood cell count go up, but it could be, yeah.
Okay, thank you. And here's one more, then we can maybe wrap after this. The question is, if there is breakdown of muscle tissue going on in FSHD, does that put a strain on kidneys and other organ systems, and should there be some kind of support, some therapy to support those systems that are being stressed by, I suppose, by getting rid of the waste product from muscle breakdown?
Yeah, no. I mean, I think the person is referring to what happens in somebody who has generalized breakdown of their muscle in what we call rhabdomyolysis. And that's when there are, many muscles break down all at the same time. And the muscle enzymes leak from the myoglobin proteins leak from the muscle breakdown and cause kidney damage. The amount of, at any one time, of actual muscle damage is not very high in FSH, and it's reflected by the CPK enzyme. And so most people with FSH have either normal or slightly abnormal CPKs in the 500, 600, 700, 1,000 range. Those levels don't result in any kidney problems. It's the people who have CPKs of 20, 30, 40, 100,000 that get into trouble. So the kidneys are not affected.
Very good. Okay. Thank you so much.
Hi, I have a quick question.
Go ahead.
Hi. Yeah, this question is about, usually the FSH doesn't seem to affect people, a lot in terms of their physical ability. But if there is a person who had a very early onset of FSH, right, in their early 8-year stage, and they're now around 50 years, they're basically totally immobile, are these guidelines in terms of exercise and stuff applicable for them, or is there something specific for people with severe FSHD? And an add-on question is there any way for them to reduce weight where they're not physically mobile? Are there any, weight loss kind of strategies for them?
So, let me take the first thing that you said. I think the misconception is that FSH is mild. We have to kind of dispel that, despite the fact that there's a big scope or spectrum of involvement. About 20% of people with FSH are wheelchair bound after the age of 50. So it's not insignificant. And as you mentioned, very early onset patients can be very severely affected. So again, that's why the recommendations are placed very carefully as far as exercise, and it really should be done with the help of the physical therapist. Depending on how weak somebody is, they're not going to be able to do very much. And maybe for these people, more kind of physical therapy, range of motion type exercises, would be helpful. But I've had patients who are very weak who benefit a lot from low impact exercise and water exercise is very good. Swimming works very well for those patients. As far as weight loss, that's tough. And I think there's no specific guidelines. They really have to work very closely with a nutritionist to kind of limit their caloric intake, but not limit it too much also to cause problems with the muscle.
Okay, thank you.
And actually, related to weight loss, maybe this can be the last question. There are some patients who have very severe atrophy, and keeping weight on is a challenge for them. What do you recommend for a patient who's, just can't put on weight and they need to?
I think it's a balance. You don't want to put on too much weight. The question is that person who's very thin, who has FSH because there's a lot of muscle wasting, but nutritionally he is eating appropriately, then I'm not sure that gaining weight in that situation is beneficial for that person, especially if they're very weak, because they have to carry more weight. But you want to make sure that they're not continuing to lose weight because of what we call a catabolic process. And so, again, you can do some blood studies, look at the albumin level, see if it's appropriate. If somebody's not getting enough nutrition, then it will be reflected in some of the blood tests that you can do on them.
Okay. All right.
Right. One more thing. Robbie, this is Bill Lewis. I just wanted to tell you on behalf of the FSH Society Board of Directors that we certainly appreciate all your efforts, not only in this program, but during all of your other research and all the time and expertise that you devoted to developing these guidelines. We certainly do appreciate all these efforts. Thank you.
Thank you, Bill. Appreciate your comment.
Sure.
And thank you so much for taking the time tonight to present this very important publication to our patients. This session has been recorded, so we will be posting it up on YouTube. And if you have other questions later on, please feel free to email them to us, and we'll find a way to answer them offline. So thank you so much. Thank you, Dr. Tawil, and I wish you all a good night.
Good night.